I'm going to talk about which is an extension of what Dr. Talwar has just spoken. It is a slightly difficult subject to understand for me. I don't know about you. I like to draw your attention because there are going to be some graphics which I would like your attention on so that I am able to impress upon my points what I want to convey. But just to promise you that those things have some meaning. And I have conducted 2 randomized trials. I have a bit of experience of which goes into 2 decades of using NIV, and I have learned from time to time, from period to period, as to why this NIV fails. And a lot of changes have occurred over the last 20 years. We never used to use critical care ventilators for NIV, and NIV has been used for more and more cases: acute hypoxemic respiratory failure, cardiogenic pulmonary edema, and new interfaces, nasal pillows, variety of masks, helmets have come. And it's very amazing, it's surprising that causes of NIV failure are as many as 40%. It could be because of the illness, it could be because of asynchrony, and I'm going to focus only on that. And these are the variety of masks that we use. You have seen majority of them. This is almost a slide which is 1 decade old. I use it for workshop where the fitting of the mask is extremely important. And if the mask is well fitting, if it is too tight, it leads to ulceration, patient will throw it away. If it is too lax, there are going to be leaks. And indeed, the synchrony of the patient and ventilator focuses on the air leak. Ladies and gentlemen, I would like to draw your attention on this graph. This is the pressure, and this is the time. This is the trigger where the inspiration started. This is the pressure, and this is the cycling. And after the cycling, there is expiration. This is the P, positive end expiratory pressure, from where a new breath will start. And this is a fundamental to the understanding of asynchrony. Now, this is the basic physiology. NIV is like a marriage, husband and wife. Some work husband does, some does wife does. And if there are leaks, there are problems. How much work the patient does, how much does the ventilator does, whether they are synchronous. If they are not synchronous, it will be counterproductive. So therefore, this is the normal breath where there is a triggering, there is a positive pressure, then the pressure, and it goes into cycling. If there is a leak, the trigger is there, the patient doesn't go into cycling. The inspiration is prolonged and the cycling gets delayed. This will lead to delayed exhalation. It will lead to further enhancement of what is called as intrinsic peak. So, how do you divide the NIV asynchronies? That is related to leaks, related to triggering, related to pressurization, plateau pressure, related to cycling, and related to positive and expiratory pressure. Now, starting with the asynchrony and leaks. There are 2 types of leaks. One is inbuilt into the machine, that you call it intentional. This is because there is only one tube from where you exhale in the conventional NIV, and the same tube you exhale. What we are discussing is the one which is preventable. And fortunately or unfortunately, the unintentional leak is as common as 76%. And it occurs more during sleep, and causes are bad type of mask, bad kind of fitting, air going into the gastrointestinal tract, and so on and so forth. Increased inspiratory pressure, too much pressure. So therefore, these are the things. And how does the leak would affect? It would affect ventilator triggering, rate of pressurization, the pressure, the volume delivered, and the cycling. And it will lead to ineffective triggering, auto-triggering and delayed triggering. Now, ineffective triggering means that it's common in ventilator-dependent patients, and when there is a dynamic hyperinflation is present, the ineffective triggering can be there. The ineffective triggering is most frequently associated with COPD because there is dynamic hyperinflation. This is an elegant European study conducted in Switzerland, Belgium and France. It's a multicentric prospective study where the EMG was done. This is the positive airway pressure and this is the volume. Now, maybe it's not a very good slide. This is the ineffective triggering. That is, patient is trying to trigger, but the ventilator is not sensing it, so there is no positive breath. Now, this is double triggering. That is, patient is already in the positive pressure ventilation. There's another trigger is coming here. All this will lead to inefficient positive pressure ventilation. And this is what is called auto-triggering. That is, if there is a trigger sensitivity is very low and patient is breathing at the rate of say 30 or 40 per minute, every breath will be supported, every small breath will be supported by a ventilator breath, what you call as autocycling. Now, the risk of auto-triggering also increases when greater sensitivity of the triggering system is set. And most often it is observed when pressure triggering is used, but this is rare with flow triggering. So therefore, somewhat there is an evidence that flow triggering is much better. What is the solution? The solution is flow triggering is better. You have to titrate trigger sensitivity, and in COPD you have to add external PEEP. How do you add the external PEEP? I'll comment later. Now coming to the pressure rate asynchrony. Now, what does that mean? That means how much pressure you should use, what should be the rise time factor, how rapidly you should give, and what should be your level of ventilatory support. Now, when you give a pressure support ventilation, the ultimate volume will be determined by the compliance and the resistance of the respiratory system and also patient inspiratory effort. As I said, when you give pressure support ventilation, it is the summation of what patient is doing and what the machine is giving. So, a faster rise time factor has been shown to unload the respiratory muscles more completely. If you give a slow rise time factor, if the slope becomes flatter, the machine delivers lower flow rates and the patient's work of breathing increases. But I must also tell you, you might like to give very fast rise time factor, but it will also lead to increased leaks. The slow pressurization would increase the inspiratory work, and excessive peak flow could also have adverse effects. It may increase the sensation of dyspnea, it may induce double triggering and lead to high peak mass pressure favoring leaks. So therefore, your rise time factor has to be not too fast, not too rapid and not too slow. Now, what is the effect of inspiratory plateau pressure asynchrony? Its ability to sustain inspiratory plateau pressure, to provide effective minute ventilation and need to minimize leaks. So how do you go about it? I would like to draw your attention on this diagram. This is the optimum pressure support level. This is the respiratory muscle workload and this is level of pressure support. If your pressure support is too low, there will be tachypnea, there will be discomfort and there will be hypercapnia. That means you are not managing, you are unable to treat your respiratory failure efficiently. On the other hand, if you are giving excessive assistance, if you are giving too high a pressure support, it will lead to increased hyperinflation. There will be delayed cycling. There will be delayed cycling because of the high tidal volume. The intrinsic PEEP will increase. There will also be increase in ineffective breath, and this will lead to discomfort. So what do? What is the solution? If you give too little, the respiratory failure is not corrected. If you give too high a pressure, there will be increased leaks, the patient will be uncomfortable, the failure rate will be high. What is the solution? How to set the pressure? One, the recent ventilators have a good capability to compensate for mild to moderate leaks. Greater leaks may compromise the ability of the device to attain a desired level of inspiratory pressure. So therefore, you can use leak compensating machines, but your clinical judgment is extremely important. You cannot be depending upon totally on leak compensation, because too much use of pressure ultimately will lead to asynchrony, which will be unacceptable to the patient. Now coming to the cycle asynchrony. Now there could be delayed cycling. It will worsen the dynamic hyperinflation and intrinsic peak, increases the number of non-triggering breaths, increases the work of breathing, interfere with the breathing pattern, and promote patient ventilator asynchrony. Now this graph I have not brought it, it has come by mistake. I again want to re-emphasize when I talk about cycling. This is the normal cycling. When everything is fine, the mask is well fitting, the triggering is good, your positive pressure is just fine, and this is with leaks. Now, if there is high pressure and there is a leak, the cycling will be delayed because of this. And what it will lead to? There can be situation that there could be premature cycling. That means there is an inspiration, but before the inspiration could finish, which could be determined by diminution in flow, which could be determined by diminution in pressure, and which could be determined by the time. Now there could be anomaly, there is a premature cycling. That means that the inspiration has been incomplete and patient goes into cycling. Now this could be because of late and ineffective cycling. And this is one of the most common situations that we see in COPD. That there is an inspiration, there is a triggering, there is an inspiration, person should have gone in cycling here. Because of leaks, because of high pressure, because of high inspiratory pressure, or because of the high tidal volume, the person does not go into cycling because the flow has not decreased. Flow has not decreased to 1/4 of the peak flow which the machine would sense. So person goes into delayed cycling. What will happen? The increased inspiration will lead to decreased exhalation time. Decreased exhalation time will lead to further increase in the dynamic peak. And that will be detrimental to this patient. Now, showing is diagrammatically, delayed cycling will lead to decreased expiratory time, decreased lung emptying, increase in the dynamic hyperinflation, that is intrinsic peak. What will lead to? Increased trigger delay, increased trigger workload, increased non-triggering of breaths, and increased respiratory muscle workload. So therefore, the delayed cycling has to be avoided. What is the solution? The cycling has to be fixed at the 25% of the peak flow. Control the end of inspiration to prevent undesirable prolongation of inspiratory time. The mechanism is to limit the maximum inspiratory time, whether you do it with the flow, whether you do it with the time. Finally, positive end expiratory pressure and asynchrony. In patients with COPD, intrinsic peak can cause asynchrony by reducing the effective trigger, the threshold leading to significant delay in ventilator triggering or ineffective effort. To largely, I have already explained it graphically. If PEEP is used, the pressure will never come back to zero. So therefore, the PEEP, as always we speak, is a double-edged sword. You have to understand it, but unfortunately, there are no ways of measuring the peak. So it has to be done by gradually increasing the trigger sensitivity and the peak. Now, how do you identify the asynchrony? This can be identified with the help of various respiratory parameters. You have to look at the graphics. By analysis of the flow, pressure and surface diaphragmatic electromyographic activity signals, as has been done by the elegant study done in Europe. Summarizing my presentation, problem. If there is a trigger failure, potential cause would be air leak, auto-cycling or increased work of breathing. What will be the corrective measures? Adjust, change the mask type, reduce trigger sensitivity, adjust triggering sensitivity or change to flow triggered ventilation. Inadequate pressurization, look at the pressure rise time. If it is too long, shorten it, or there may be the pressure support is too low. What is the solution? Reduce pressure rise time, increase inspiratory pressure. Failure to cycle. If there is cycling is failing, look at the air leak, look at the high end expiratory flow, adjust or change the mask, increase the end inspiratory flow and threshold, and set the time limit for inspiration. Ladies and gentlemen, and chairperson, I thank you for your kind attention.